So I wanted to welcome everyone today to the April HSPRI Research Rounds. I want to start by acknowledging that those of us attending from the Kingston area are situated on the traditional Anishinaabe and Haudenosaunee territories. It's these transitional times of year, with the classes ending, students leaving, always cause a time of reflection. And I offer a sense of gratitude for these lands, which we've come together to learn at Queen's over the last school year, through diverse lenses and experiences, and with appreciation for this diversity. I want to thank each of you for taking the time over the next hour to be present as we consider how our research at HSPRI can support principles of equity, diversity, and inclusion. Today, as we listen to Dr. Michael Green, we consider how these principles can be applied to our understanding of how we use data positively to inform health policies and decisions that support a better and more equitable system. And also to acknowledge that data may miss voices and people, and that we must work together to include these going forward. I'm extremely pleased to introduce Dr. Michael Green today. He's one of the core faculty at HSPRI, a professor in both the Departments of Family Medicine and Public Health Sciences, and also head of the Department of Family Medicine. Dr. Green is the co-lead of INSPIRE Primary Healthcare along with Dr. Rick Glazier. They work closely with both the Ministry of Health and Ontario Health to support primary care health policy and decision-making in the province. And Dr. Green is also highly involved in our local system as co-lead of the evaluation support structure. Dr. Green is here today to talk about the recent release of the updated primary care data reports, and more specifically to talk about the data as it pertains to our region. Mike, I will hand the floor over to you.
Hi, thanks everybody. Welcome to the rounds, and thanks Catherine for opening up and the acknowledgement of territory. So I'm going to share my slides here, and we'll get started. All right, just want to verify everybody can see that okay for me. Elliot, give me a thumbs up. That's great. And maybe I'm going to ask Elliot to monitor the chat and bring questions forward so that I can focus on talking. So welcome everybody. I know that there's a diverse group of people on the rounds. I understand we've got some people joining us from both Ontario Health East and Ontario Health West, as well as recognized names from our local research community, our Ontario Health team, our public health unit, and some of our municipalities and community partners. So welcome. I just want to start off by acknowledging our team. We have a great team at INSPIRE-PHC Healthcare, and the attachment work has really been led by this working group that's listed on this title slide, and I just want to give the whole team credit for the work. This is a monumental amount of work that we're doing on a regular basis to try and respond to concerns about patient attachment and other access to primary care returns, primary care across the province, and couldn't do it without the team. And thanks also just to acknowledge our funders, Ministry of Health, who have been supporting this work for a number of years now. So many of you have probably seen this. Some of you may not have. This is an older graphic that we're actually in the process of updating for this year, looking at in 24 hours in Ontario where care is delivered. And this is just to situate the central position of access to primary care. And in particular, the data we'll be talking about is predominantly about access to family physicians, because we have limited data on things like nurse practitioner-led clinics. We are able to include some community health center data in our reports around attachment. But as team-based care rolls out, that data gap's important. And just this general view has not changed much today. So if you think about the challenges our health system is facing, if you're always focused at the little pointy end of how many people are going through for a particular type of surgical procedure or through an emergency department, and you're not addressing the foundational work of primary care and delivering care to Ontarians every day, then it's going to be difficult to make progress. So just as a some of you may be familiar with our reports already, others may not be. So part of our role in our research program is to help support Ontario health teams with data about their Ontario health teams, and in particular, how the patients who are attributed to their teams are attached to primary care and what sorts of primary care services they receive, both for their whole attributed population and for certain priority populations. And so the information that's available on the reports, and we'll show you how to get to them later, they're available on the web, so you can look at the details of them at your leisure. I know that here in our OHT, I've done some work with different working groups and the leadership team kind of presenting on the data so it can be understood. So we look at who's attached, and how did we define that? We look at who is, explain some of the acronyms. A patient enrollment model, that's the PEM. That is if your doctor is in any one of the models of care in Ontario where you sign up to be a patient. So that could be in a family health team, a family health organization that doesn't have a team, a family health group. As a patient, you might not know if you're in one of these, but in our region, most physicians are in one of these enrollment models. If you're not signed up with one of those groups, we then look at whether you're virtually rostered, that's the VR. It means that you've had visits to primary care and you're attached to the doctor who's seen you the most. But we've limited. We're worried about walk-in clinics. I think it's less of an issue in our region. It's not it's not like Toronto or Ottawa where there's a lot of standalone walk-ins. We don't, if the doctor you've seen doesn't see patients more than once, so they see less than 1 in 10 of their patients more than once, we figure they're working in episodic care in a walk-in clinic. And so we just say, probably shouldn't attach you to that doctor because you're probably not, that's not a reliable source of care. We also look at who's visited a community health center. And we do, for children, we do the same thing with virtual rostering, except we also look at pediatricians, not only family doctors, and we use a slightly different set of codes. So that's how we say who's attached. The people who are left are 2 groups: people who haven't had any primary care, but they may have been to a hospital or emergency room or something else, or maybe they didn't have any health service use because they were healthy. Or maybe they have had a primary care visit to one of these low continuity doctors. So that's this uncertainly attached who have had primary care are people who've been attached to somebody who's low continuity and probably in a walk-in, and the rest are not receiving any primary care. So that's how we figure out who's attached or not. Then inside the tables, we report on a whole bunch of things around the patients, and we do this by their attachment status and by which type of care they're attached to help Ontario health teams understand the connections between their patient populations and primary care. So we look at the demographics of patients: age, sex, whether they're rural or urban, their income levels. We look at some other characteristics for patients. We use some indexes to look at marginalization. We look at whether or not they've recently arrived in Ontario. We look at the degree to which they have multiple medical conditions or comorbidity. We look at the degree to which they're really sick in a particular year, which we call morbidity. And we look at whether they have particular chronic diseases: chronic lung disease, congestive heart failure, diabetes, as well as whether they meet a definition of maybe having frailty. We also then look at, specifically within primary care, which type of those patient enrollment models they're in, how many primary care visits they've had, what the continuity of care is for their visits, what their follow-up is like after they've been to hospital. And we look at some other measures of healthcare utilization. Were they receiving palliative care? Are they receiving long-term home care from home and community care? Have they had a mental health or addictions diagnosis in the last couple of years? Have they been to the emerge, and what acuity level? Have they were admitted to hospital or not? Whether these were a subset of visits that are considered sensitive to work in primary care. We call the ambulatory care sensitive conditions. And again, as I said, how often they're readmitted to hospital after they've been discharged. And we do that for the whole population in the Ontario Health Team, but then we also do it for some subgroups. So some of those characteristics that we've measured, we do a deeper dive and provide fairly detailed data on what each of those things looks like, not for just everybody in the OHT, but say only for those who've been to the emergency, only for those who've been hospitalized, only for those who are frail or on home care or have mental health diagnosis or palliative, for example. So that's what's available in the charts. There's lots of charts, lots of fields, lots of data. Can be, our team's always happy to have you reach out and talk to us if you have questions about the data, if you're looking at your reports. But the full Excel tables are available on the web, and we'll show you how to get to those in a minute. I see there's a question or comment in the chat. Elliot, is that anything I have to answer? Will you shout me out if there's something I need to explain? And oops, sorry, I went too fast. Here we are. So this is where you find the data. This is on the ontariohealthprofiles.ca, the Ontario Community Health Profiles Partnership website. And although Ontario Health Teams are not geographic entities, they are by definition made of networks of patients wherever they may be. They're all centered on a base hospital. And so this map, which lets you find your OHT. So for the FLA one, you can see that's that 1014 there on the map. It is based on the shortest drive time to the base hospital. So in this case, it's like that boundary is KGH is the closest main Ontario Health Team base hospital to where you live. Some hospitals don't count as base hospitals. They're part of a network. So for example, the Napanee Hospital is a part of the Kingston network. So the drive times are based on KHSC rather than Napanee as an example. There are, I'll talk more about the data limitations after, but we did just update some of the data for 2022 because we had done a previous run a couple of years ago. So what's new in our update? One is that we've now brought the data up to March 31st of 2022. All of this information is based on data at ICES, which is these linked administrative data that is created by every time you go to the hospital, the government has to pay for it. And there's some data that's submitted back to cover that. And so we link it all together with things like the census and some other information you have when you register for a health card and those sorts of things to pull the data together. But it means we're always looking in the rearview mirror because the data doesn't get there till after you've received a service, and we have to give it time to arrive and be cleaned up and all that. So March 31st from last year, so a full year ago, was the earliest we could do a complete update. We've also, in our previous report, only reported on kids under 18. There's a lot of interest in pediatric care this year, particularly with all the stresses on hospitals during the last spring's COVID wave, whatever wave number that was. I lost track, 4, 5, 6, or they all flowed together. And so we now have some age breakdowns available. There's a major data limitation that everyone needs to understand for that. And so I'm going to present some geographic data as well, because this is a big issue, particularly for patient attachment. And that is that the way that your Ontario Health Team has been informed about who's your attributed population, that has not been updated. So it hasn't been updated for a while. And in fact, there's probably a need to change the methods a little bit to deal with particularly patients who don't have any access to primary care. So we are working closely with the ministry and Ontario Health and the Ontario Health Teams group at the ministry on some thoughts about how that can happen and what needs to change. So that means that anyone who's new to Ontario, who's born, died, left Ontario, that like there's people left out. And importantly for here, it means anyone who arrived to the kind of geography of your Ontario Health Team who wasn't previously attributed is not counted in your population. I'll show you the impact of that. So your numbers will have gone down. So what you'll see is, though, even there may have been population growth or people moving in, the numbers of attributed patients in your Ontario Health Team in this updated report is less than it was on your first report. counterintuitive maybe, but it's because we haven't been able to add new people. We've only been able to take people out. So we've taken out people who died, people who no longer eligible for OHIP because they've left, or there's some things like a maximum age in years since the last time they had an OHIP billing, and so they've been dropped out. And just to give you a sense of what that looks like for the different OHTs, including like the OHT here and FLA, which is the focus for today, is that the original population that we had for this was around 215,000 people. There's now closer to 208,000 who are actually remaining in the attributed population. So if you're looking at this, if you've looked at the data over the 2 years and you want to look at what was it like a few years ago and what is it like now, you just have to be aware it's following only the people who stuck around. They may also be misattributed. They might be actually have moved to a different OH, maybe they should be in a new OHT now because they moved, but they haven't been able to correctly reassign them to a new Ontario Health team yet. I think we kind of covered that. And I'll skip that. That's just we're gradually rolling them out for all the different OHTs. So for some of these, I'm going to talk about Ontario-wide, because Ontario-wide, we know the data is complete. We don't have to worry about that not being attributed to an Ontario Health team, because this is just looking at everybody in the province. And so what we know, what happened between 2020 and 2022, the number of people who look like they don't have a regular source of primary care increased from about 1.8 million to about 2.2. And as a percentage of the population, it rose from about just over 12% to just under 15%. For kids, there was a bigger jump. There are some particular reasons why this may be true. So like, this is very alarming to people looking at this. This is, I think this might start to fix itself a little bit. I'm sure it went up, and I'm sure it went up by more than the adults. That's been my personal experience on the ground as a family doctor in Kingston. The first time ever had been seeing unattached babies and kids. But there are some data considerations for kids. So just if you're looking at this, the way that kids are attached, more of them are attached through this virtual rostering, in particular because of the role of pediatricians. And there was a lot less care. There were a lot less visits and care delivered over. It's a 2-year look back window. So there were less kids being seen in these billing situations for colds and flus. Like the COVID assessment centers were open and didn't bill. So like if you took your kid to the COVID assessment center, in the past, they would have been counted as having had a visit and be attached to somebody. But in these last 2 years, if that's where they were seen, then it's like, it was like they disappeared. We didn't have any data on them, so we're not able to attach them to a source of care. So unless they're actually enrolled in a patient enrollment model or making regular visits, then we can't attach them. There also was less circulating respiratory virus for a while, except for COVID during the period. So there were probably actually some lower visits for some of those reasons also. Other thing I want to talk about is teams, because these teams are super important for a number of reasons. And one of the other things we do have available, I'm trying to remember, Elliot, I don't know if this is on the website or not with the data update, but we have a sense of who has access to team-based care.
It's not posted yet, Mike. We do plan on posting it shortly.
Okay, so this is looking across Ontario at the percentage of people in each OHT who have either access to team-based care, access to non-team-based primary care, or looks like they don't have access at all and are unattached. And so for each of these circles, the green slice of the pie is that you're attached and you're attached to a team. So that could be a family health team, or it could be a community health center. The missing information is about nurse practitioner-led clinics. So if you were going to a nurse practitioner-led clinic, you wouldn't be in because we don't have your information. And then the sort of tan-colored one is that you have access to a family doctor in one of the other models. So either if you're in a team-based practice like a family health organization that doesn't have a team, or you're in a more traditional doctor's office like a family health group, or even in fee-for-service practice. Not really an issue for our area. We really don't have significant presence of that. And it just gives you a sense across the province where it is. And you can see huge variation. Some of these pies have a lot of green. Some of them have a lot of the dark brown, which is the unattached. And I'll show you our Kingston one has a close up a little later. We're actually pretty good. We actually have a higher amount of team-based care than most regions. And the reason this matters is that having a team makes a big difference for things like hospital readmission. So this isn't our work. This is from Team Interprofessional Care. Their website thing is there, but this is looking at readmission rates to hospital across Ontario based on whether you're a patient of a family health team, a patient of a non-family health team fee-for-service type model, or not having access to a physician. And you can see a dramatic difference in the readmission rate. So it matters for your hospital and your Ontario health team if your primary care population has access to teams. Talk a little bit about the unattached patients. This is where we're going by geography, because as I said, we can't figure out where the new people are, especially kids. Like any child that's been born in the last couple of years is not attributed to any Ontario health team because they haven't rerun that model. And so in this map, what you'll see is this is the darker the blue, the more kids there are who look like they are not receiving access to care right now. And this shows you across the whole province. You'll see that, in the FLA OHT here, we're actually not nearly as dark blue as places like Toronto or Ottawa or that, but you can see there's still some variation across the region in terms of where the concentrations of that might be happening. And this is just for all ages. Same sort of a map again. In this one, this is attached rather than unattached. So dark is good. The darker the color it is, that means more likely that the people in that region do have access to primary care. And at least in terms of attachment, doesn't mean they're able to get in to see their doctor. It means that they have a doctor's office they're attached to. And again, you can see here in the FLA region, we're kind of in this in between sort of a rate. And when we look at uncertainly attached, these are the people who look like they don't have access to care. Again, in this case, darker means more people without access to care. And you can see that some of the rural areas, even there's not a lot of people there in some of that's a park. You may like to, but as a percentage of who is signed up with one of these groups, you can see that it's really that we're kind of in this 15 to 20% range for a lot of the kind of urban part of our OHT. This is just a close-up of where we're at for our teams. We have pretty good access to team-based care here. It's over 50% for our OHT level, and it's growing. Some of these things aren't counted yet very well. So if you're on from NAPNE or from our OHT, the new interprofessional care team that supports NAPNE and the rural Frontenac FO, not all of your patients will be counted in this. They'll only be able to count them if they actually had a visit with one of those interprofessional team members. So it probably, our coverage is actually probably even a little better than this. And it shows we've got a pretty strong foundation for working forward. But we still have this slice of people who have nothing. And I think that's a big focus of the work in the OHT around attaching people and dealing with that slice, even though it might be smaller that as a percentage than some of the other regions, is still a lot of people. So we'll just carry through on a little bit of the details of who's not attached and what we know about them for our attributed population. I will note this slide, it's based on the attributed patients. So this is missing people. Just remember that this is about the people who were already a part of our OHT 2 years ago and where they're at now today. So the number of attributed patients went up to just under 20,000. You'll see why I think that's a significant underestimate if you look at the geography, because this is only the attributed patients. So there'll be more on that on a future slide. There are certain groups that are overrepresented. So new Ontarians more likely to be uncertainly attached. So if you look at our attachment rate is still higher than average for the province, but this 24% is higher than the provincial average. And so, new Ontarians more likely to be uncertainly attached. Low income. If this was perfectly fair, and we do income by groups of what we call quintiles, or 20% in each group. The lowest income group represents 30% of the patients who aren't attached, whereas the highest income group is less than 20% at 17. So we see that income gradient. And then the good news is actually that for people who are sick and have conditions, they're actually more likely to be attached to care. So that's a good thing. But there are still significant numbers who aren't. So for patients with mental health or addictions diagnoses, there's close to 3,000 attributed patients in that group who currently look like they don't have a good source of primary care. And even for diabetes, there's over 1,000 patients with diabetes in our region who look like they don't currently have a good source of primary care. So these are important things you think about. What's your life like as a patient with diabetes? Trying to navigate the system without access to primary care would be very, very difficult. I'm going to skip. This is just by postal code. The only thing I will just let you know is that none of our postal codes are in this list. So no matter how bad it is here, it's worse somewhere else. Just leave it at that. This is where I actually haven't had a chance to dig in. This is a new slide, so I haven't had a chance to dig into it. So I do, Elliot, I haven't had a chance to look at this KOK number because it's so high, to make sure there's not a data error on that. So I do want to flag in case that's off, because I'm not even, but whether it's right or wrong, regardless, when you add all these numbers together, you'll see there are significant numbers of unattached patients in all across the region. What you see is it doesn't matter if you're downtown or in the East End or the West End or in rural or whatever, there's like big numbers of patients who aren't attached all across our geography. And this number, because it's geographic and is not based on the attributed populations, is way higher than 19,000. So before I did add it up, I want to double check the KOK one before I give people a final number, but it's like way higher. Elliot, do you trying to, I see you're just nodding. It's just like, if you add these ones up on the slide, it's over 40,000, but I
think Mike, part of the explanation here is these are done by FSA, and I think the FSAs overlap with respect to the OHT region.
So this KOK may actually go into somebody else's OHT as well, because they're not perfect boundaries. So, but
Mike,
regard.
I did this. The KOK overlaps with regions in Belleville and Prince Edward County.
Okay, perfect. Thank you. So that's the answer. That's why it's so big. It's just it's a big forward sortation area. And actually I know for sure from talking to my colleagues in Belleville and Prince Edward County that unattached patients are certainly a significant problem for them for sure. But this still gives you an idea that the scope is bigger. It's more than that 19,000. It's definitely more. And more by this gives a sense of the geographic spread across the region. Talk a little bit about kids priority populations. This is within kids. So this is looking at the bars. It might not make sense for a shorter bar to have more numbers on it, but the numbers are the actual numbers of people. The heights of the bars are the percentages, which are up and down along the side. So the light blue is all of Ontario. The dark blue is FLA OHT. And so what you can see is that for kids who don't have a good source of primary care, they're more likely to go to the emergency room in our region than they are generally across the province, but they are less likely to have been hospitalized or to have been seen for a mental health concern. When you look across all ages, and we look at that again, you see as a percentage, uncertainly attached patients, that there more of them were likely to have received service in the emergency department compared to the province overall. And then here's where it's different from kids. I think when kids have health issues, they get connected a little more quickly. They were more likely to have mental health conditions and more likely to be in hospital than overall for the province. So this is the sort of data that we have. I did want to point out one thing is that, you know, with people who aren't receiving care, we don't know for sure who's looking. So what we do know is who had a primary care visit. So of those 19,000, at least 6,000 of them, more than 6,000 of them, had a primary care visit to some kind of walk-in clinic. So we know that those people for sure are looking or requiring some form of primary care. What we don't know is who is not seeking care, or who has sought care in other ways. Did people call, you know, Maple or TELUS, one of those private service things? Did they just go to the, you know, some of them may have just gone to the emergency department. This is related to, they may still want a primary care doctor. Others may have given up and said, I'm not finding a doctor, so I'm not looking and I'm not trying, and may not be receiving care. And even out of this group, there's a subset, 3,000, who, you know, they had to have at least five walk-in visits essentially during the prior 2 years. So these are people who need not just, you know, a single episode of care, but really should be connected to some form of care for sure. So they might be a priority group for trying to get attached. Mental health is a big issue. High users of the healthcare system. There's about 3,000 for sure of our attributed population with mental health diagnoses who look like they don't have a source of primary care, and that likely should be a priority for work on attachment. But the good news, as we said, is team-based enrollment is high. Like we have good access to team-based care, so we've got a pretty solid foundation for figuring out how to extend this out to cover the whole population. We know team-based care is important. We know it's going to be a priority for government initiatives in the coming years in addressing some of the health system challenges that we're facing, and we're starting, I think, from a good place. And then this other question is these non-users. Like there's a lot of people who aren't currently connected to primary care, and many of them might be helpful to have them attached, but they're not going to be a big burden on the system. So I think also, you know, as a family doctor, when people are like, oh, can you take any more patients? It's like, you know, these 13,000 patients are not hard to connect with my clinic and say they're part of my clinic. If they need help, they'll come in, but they're not putting a big burden of care day to day. But it is in figuring out the balance. How do we help, you know, teams that are willing to take on more patients end up with a balance of people who need a lot of care and those who may be requiring less, so that it works out for the practice overall. I'm going to pause there for comments, Elliot. I know there were some extra slides, but I think I will skip the extra slides for the moment and go to questions and discussion. I see all kinds of things in the chat, but I haven't been able to see the chat. So maybe I'll stop sharing for a moment and see if there were questions. People can stick up their hand or throw something in the chat.
Mike, Rob had a good question early on. Rob, I'm just going to hand the floor over to you.
I've had a couple of comments in there, Mike, but one was about the slide you had about the structure of attached, unattached across the province. And it looked to me like, by and large, even though we're doing pretty well here, it looked like it was kind of a similar picture everywhere. And so my question was, does that suggest there's some kind of a structural thing rather than the performance in each individual area that leads to kind of a third, other than maybe here and in Toronto and a couple of isolated places?
Oh, are you referring to the map, like the different?
Yeah.
Yeah. So there's absolutely structural things. So one is that the requirements for establishing team-based care when it was first rolled out meant that doctors had to be in one of these alternatives to fee-for-service payment. And that wasn't even across the province. And then it was up to each group to decide if they wanted to apply to become a team. And as they were in the midst of rolling, they did it in waves. And as they were in the midst of rolling that out, then they got concerned about the overall cost and what it was going to look like, and they stopped accepting new applications. They also stopped letting doctors get off of fee-for-service and get into capitated payment models. So a bunch of things happened altogether. And what that meant is that the early adopters of payment that was off of fee-for-service, which was often smaller cities like Kingston or rural areas, were the first ones out of the gate, both with the changes in payment and with the teams. And actually the largest numbers of patients, and usually the lowest percentage with team-based care coverage, and the lowest percentages of doctors in these alternate payment models are mainly large urban areas. The big exception is Hamilton, which actually got very organized early on and actually has quite a bit of team-based care and most of its doctors in one of these alternate models. So they're structural. And then the other structural thing is they just didn't train enough people. So like, there's population growth, and population growth, Ontario is set to grow by a large number of folks in the next 5 to 10 years. So if you don't follow the federal politics, there's increased immigration targets for Canada for the next 5 years. I think they're talking about welcoming something like 5 million Canadians or something like that. And I do believe that the estimates are that large percentage of those, probably 60%, are going to land in Ontario. And they're going to need care. And their care needs were not taken into account when planning for how many medical students and nursing students and NP students and PA students and everything else was put in place. People graduating now, their training started a decade ago. So there are definite structural issues in terms of capacity as well.
Yeah, I was trying to relate that to the attachment part. And I thought, for instance, if there's a mobility factor of people moving from place to place of 20%, then you're always going to have people delayed in attaching to a new physician as it may come along.
Yep,
that too. Yeah.
Well, I don't know if you know anyone who's moved, but like my patients are afraid to move, which seems to me to be pretty crazy that, someone's like, I'd like to move to Ottawa to be closer to my grandchildren, Dr. Green, but I'm not going because I can't get a family doctor in Ottawa, and I like coming here. So, it shouldn't be that that's a driving force for someone's decision about where they live, but that is currently the status of things.
Mm-hmm.
And Kim, you had a comment. I think that happens a lot too, just that your doctor, people keep driving back and forth to see their physicians.
When we fix that in the attribution data, it'll all be mixed up.
And just see in the chat, Kathy, you had a comment more than a question. I don't know if you want to speak to that at all, or I think you've put it nicely in the chat as well. But the retirement.
Yeah, I think we need to keep our eye on that, because I know that one of the family health teams, a lot of their physicians are retiring at the end of May or the end of June, and there'll be another 7,000 or 8,000 unattached patients. And that's just from the one I know, not other individual practices or other physicians coming up for retirement. So
and that is one of our challenges, Kathy. This data is always out of date, right? Like this update takes us to March of 2021, and a lot has changed since March of 2021.
Right, and it's historical, not it's not looking at trends going forward.
Proactive in healthcare, really? I think that, Kathy, so that group of physicians is actually they're the newest folk, but they're not part of a family health team at this point. And so that, when we get to that data, it will change the brown part to bigger and the team-based care about the same. But Mike, it worries me a little bit because, when you compare across the province, we're not as terrible as some other parts in the province. And part of that is proactive planning, and places like, Catherine, to your point, Hamilton and Guelph, Peterborough, I think, organized themselves really early when there was opportunity to do that. And it makes me worry just a little bit about this data, recognizing it's old, and OHTs have had the opportunity over the last 2 years to try and make some changes to Rob's point, organization and structure to be able to deal with these issues. But the data from 2 years ago is never going to line up with the abilities of current Ontario health teams to actually make change. So any policy or program funding that they put in now will be, to what was before, without sort of any sort of thought about where it can best be used. So I almost wish our data was worse, I gotta say.
Well, I'll maybe say, you're right. I mean, it does mean that I think the priority for new teams is going to be the places that didn't have very many teams. But I think what it lets us know here is how big our gap is and where we can go. I really think that until they fix the attribution model, we're probably going to have to revert to using some of the geographic stuff to try and stay a little bit more up to date. And so I know the direction for Ontario Health is to use attributed populations instead of geography. But to make that practical for Ontario Health teams, that means the attribution has to be updated regularly and kept up to date. So I think that's a bit of work that they're aware of that. I don't think that's not news to them, and I know they have a plan to kind of move forward with it. But until it happens, I think it's going to be a little bit of this back and forth between the different data sources to understand where things are at versus where they were.
And Mike, I just noticed that Christina Canton has a few comments in the chat as well. Christine, I don't know if you want to take yourself off mute, or Mike can easily speak to them as well.
Yeah, I just thinking about the larger picture, and I understand it's very complex, but the piece that we hear, the stories of the families, it's so important, right? And that's to Kim's point about it's happening like right now. And if you have a family that they're afraid to like move, to help support their family or whatever reason, I mean, that's a life thing, right? Like that's a quality of life consideration. It has impacts for like how we care for children and if they have like grandkids and all kinds of stuff, So it does affect our communities, like from a health perspective and a social connected perspective when you think about mental health. So, data is really valuable. It's really important, but it's this qualitative story piece that is also really important when we're designing and refining our health and social systems. When we think about social determinants of health, housing, income, like all those things that we all know, like makes a really big difference. So I just wonder how the two pieces, the data with our qualitative understandings come together when policy is being considered.
Yeah, no, you're 100% right. The data is helpful for some things, but it's never enough by itself. And those, the narratives of people and what's happening in their life are definitely a critical piece of it. Look, it's all.
Dr. Green, thank you so much for an excellent talk. We enjoyed it. I'm one of the cardiologists from KHSC. And my question to you, it's really nice how you outlined the data, and I'm delighted that we are not as bad as other places. But what do you think, how do you think specialists can contribute to solving this problem? Would it help if we can identify some of the patients that are unattached that maybe it should be prioritized in that ministry list? Because I know I have some of my patients that have 7, 8, 9 comorbidities. They are on tons of medications. I'm renewing their insulin and their stuff because they have no one else to look at. So I wonder what is it that we can do from our end to help?
That's a great question. I'll tell you what I think, and then I know there's other lots of other care providers, family docs, specialists, nurses, midwives, others on the call and might have their thoughts. I think helping with the flow and burden of work so that we can have the capacity in the community to take on the primary care by working on things like better care pathways, or making sure that there's not additional administrative work downloaded to the family docs related to their specialty care. Those sorts of things can give us capacity in the community. Like, doesn't make any sense for you to take on diabetes care. You should be focusing on the specialized care that's your area of practice. And so I think that it's participating actively in the flow and working for the solutions that will kind of help us to be able to focus on the core parts of our jobs, and to liaise quickly with the hospital. Like, I think for Kim, I don't know what you think, but the stuff that I've seen recently at a few meetings I've been on the amount of work that's now additional work in primary care, not our core primary care, on kind of managing patients on wait lists, or managing work that's like a pre-workup for a specialist visit or a follow-up for a specialist visit, takes away from our capacity to maybe be able to take on some of those unattached patients and take that work that you don't want to do onto us, and keep the work in the right buckets. I see some nods. I don't know if anyone else has other thoughts.
Mike, I'm also just wanted to pick up, Christina made a comment, and I know that I think OH West used your data for HHR planning. I don't know if you wanted to comment on the question she had related to how this data might be used for HHR planning.
Yeah, I mean, it's again, it's looking backwards, not forwards. But it at least gives you some measure of not only who's not attached, but what their burden of illness is. So the deeper data tables allow you to look at those characteristics of the patients who aren't attached. You know, are they, what are their medical conditions, where it's at, and it can give you a bit of a picture of, you know, how much of this is, you know, generally well healthy people who don't need a lot of inline, you know, care today, but who versus those who are a higher burden. It also, I think in some ways might help with HHR planning. Like, I think about those people being seen by doctors with less than 10% continuity, which is really low continuity, right? Like, that's like, you know, if you see each of your patients, like if you saw 10 patients and you only saw one of them twice, that's not kind of what I picture as continuity of care family medicine. But that means that there's people providing needed care. And so I think it also would, in some areas, give you a sense of what might be the capacity in your area for physicians who are engaged in that kind of care to maybe contribute to comprehensive primary care in some ways. How do you bring those walk-in clinic facilities and things into the picture? It's also the way that a lot of ways did it before was only with the patient enrollment models. So they had the data only on, they didn't have any of that virtual rostering or community health center or pediatrician type of data. And it really inflated the number of patients who were unattached. And it often made it seem like it was impossible to achieve a goal of trying to get people connected. So I think that providing the different perspectives, like who's formally signed up, who's getting care in other ways, what's our real gap? Like, there's no one truth. But having these different views can help get a better picture of where you might prioritize your health planning for the future. I don't know if anyone from OH West is on. We've had I'd love to hear from them what their perspectives are if they're on the line.
I'll just jump in a bit here, Mike. I know that the OH has been very keen to get our FSA data and look at attachment and attachment patterns, and looking at locating or beefing up the teams in those areas where the attachment numbers are low, both with the entire population and with the pediatric population. So we have been working with Ontario Health West. I think Lisa Armstrong is on the line. She's from Ontario Health West. Also Ontario East, we regularly share data, and also we share data with OH overall with Liz Mugga and her team at Central OH. In addition, we share the data with the primary healthcare branch. They're very keen. There's many players in this space. And so I think just about all the players are using a variety of data points, including ours, to try and address the crisis that is access to primary care right now. Alicia, I don't know if you wanted to comment further on that.
Yeah, no, I think that was really well said, Elliot. We're certainly using this as sort of a piece of our, a piece of the puzzle, looking at the unattached, but really also, other factors, including the marginalization of those groups. What does the frailty look like in the unattached? It was said before that it's a good thing that, the majority of the sick population is attached, but really looking at who is still sick and who's unattached and what that looks like in certain FSAs and in the OHTs. So considering the marginalization, rurality as well, and taking into consideration, who has team-based and who doesn't. So lots of other pieces coming into this, but this is such a great piece of information to have. And yeah, we're looking forward to more work and more digging with the data.
Great, thanks. I got two questions that I'll reply to. One, Rob, your question about continuity. We actually looked at this and it's different. Depends on whether you have a regular source of primary care or not. So if you were a patient who has a place to go, like you've got a family doctor or you're seated at a CHC or attached somehow, we have to talk just about the doctor numbers for continuity because that's where we're at. So like if you had somebody before, the pandemic and the introduction of virtual care actually caused a short-term increase in continuity, a little bit of a glide off for over a couple of years, but not much. It's actually still higher than the baseline before the pandemic. If you were someone who was not well attached, it had a significant negative impact on your continuity of care, and continuity care dropped in a big way. That's not a part of this data set study, but it is a part of the kind of body of work that we've done in INSPIRE Primary Healthcare. So I know that I'm not sure if any of these are the Ontario Health Profiles website. They're for sure on the MAP Urban Health website and on links through the INSPIRE. This is work that our attachment group has done and virtual care group, Rick Glazier and Tara Kieran from Toronto playing a lead in those, but we've tracked it all the way through the pandemic. And so if you have a doctor, it's good. If you don't, it's being bad. And then to Christina's comment about newborns, for sure, that's been an issue here. I know the model of care is different in different types of professions. So, I know in family medicine, even though we have like most well baby care would be by appointment and people fit them in as they need. But the people who aren't attached and the biggest challenge, I think, in our community has been this question of people not wanting to give up their doctors. So like, someone moves to Kingston, they have a doctor in Toronto, they're pregnant, they don't have a doctor in Kingston, they have a delivery, especially by a specialist. They don't have a family doctor yet for their baby. And then they're in this position where they really don't have anywhere to go. So we've been working on that as an OHT, trying to have some projects both to all of the practices in our region are very collaborative through our Primary Care Physicians Council and our Primary Care Alliance table. And we've put in place a process to help women who are pregnant who don't have a source of care get connected with a source of primary care so that they'll have for them and their babies afterwards. And also for unattached newborns, been working on that as well. And Kingston Community Health Center has been playing a lead administrative role in helping do that, but all of the practices in the region have been participating.
Thanks, Mike. I'm just thinking we've got about 5 minutes left, but I know it's a sunny Friday afternoon. I don't know if anyone else has any further questions or comments. Thanks, Lynn. I just want to note a few things. Lynn put a link to the MAP Center for Urban Health Solutions, but also early in the chat, Sherry had put the link to the data set as well for people if they want to take a look. Well, Mike, you know what? I'm thinking 5 minutes before 2 might not look so bad here on a Friday afternoon. Thank you so much. There's just so much to dig into. And I think honestly, it's just kind of figuring out all the different angles to look at the data and to think all of that is just from our region too. And each of the regions can dig into their data like that for some health system planning. So thank you so much. It's so exciting to see this work and so what an influence this is having in our province. Thanks, Mike, and thanks everybody here today, and enjoy the weekend.
Thanks, everybody. Have a great weekend, and thanks, Catherine, for inviting me.
Thanks for coming.